Hello and welcome to today's episode of the Pediatric Consult. I'm Dr. Jill Schaffeld, your host for today, and I'm in the studio with Dr. Marielle Kabbouche from the Division of Neurology at Cincinnati Children's. Today's discussion is on migraine diagnosis and treatment. So welcome, Dr. Kabbouche. We're very happy to have you here.
Thank you for having me. It's a pleasure.
Sure. So before we get started, we'd like to just learn a little bit about you, maybe just some practice interests or how long you've been practicing at Cincinnati Children's.
So I've been at Children's for about 24 years. I did my child neurology in Vanderbilt in Tennessee, and I moved here to do my headache fellowship, and I've been here since then. I worked initially on acute treatment in the ER as inpatient, and then in the last 2 years, I've been the headache center director.
Wonderful. Well, thank you and welcome. Very excited to get started because I feel like this is definitely a topic that, of course, primary pediatricians, as well as, other general practitioners see on a daily basis. And sometimes I will admit it's not always migraines, So I'd love to have someone here who's an expert who will really kind of help us through navigating these patients. So just to kind of jump right in, if we are seeing a patient, I feel like the majority of the time, occasionally we see an acute headache that walks in that's, an acute migraine. But the majority of the time when I see patients for headaches, I would say 90% of the time it's, let's discuss these chronic headaches and maybe they're not having one at the time. So I think very importantly, let's go ahead and dive into what would be some very specific things that we should ask the patient in our history or things to kind of elicit about the chronic headaches or whether even those are migraines and how to get to that diagnosis.
Correct. So first, migraine is a really frequent disorder that can be very disabling. Kids sometimes don't even dare telling their parents because the reaction they will get, just a headache, just go lay down a little bit, or you don't want to go to school, which make them wait too long and they end up in the office with chronic headache like you described. The first thing we want to make sure, and this is the worries of parents when their kids have chronic headache, do they have a brain tumor? Do they have something else going on? So I think the patient walking in the office, that's the initial evaluation that needs to be done. So how do we do it? The history is important. When the headache started, and usually the patient remember the bad ones. So you want to make sure you tell them, did you have small headache on and off before? I know you have a bad one now. So the history, the length. Has it been more than 6 months, more than a year that you've been having headaches? The second part is how frequent they are, the severity, the disability. And then you go to the family history and the general history. The next step would be the exam, which is very important. So a regular physical exam and a neurological exam. Just having those in hand, it will be much easier to make the diagnosis. So what you're looking for are what we call red flag, yellow flags. Is that an acute headache? They never had a headache. Suddenly they have the most severe headache. You want to be concerned about something else, a vascular disorder, an infection. So that's one red flag. If these headaches always wake them up from sleep, you get concerned. They wake up, throw up. Can it happen with migraine? Yes, but I'll be a little bit concerned. An occipital headache, it can be migraine, but that's very unusual in kids. If they always pinpoint it's in the back of my head, because most CNS abnormalities are in the occipital area in the back of the head. So
right.
you do get concerned. Other one, of course, if the physical exam is abnormal, if the neurological exam is abnormal. One thing I always add, if there's a big concern from the mother, I do trust them. That was very important during telehealth because the exam was a little bit hard. So I had patients saying, the mom said, something is off with my child. And I would take it seriously. Something is off. I do believe the mother, they live with their kids. They know more than me. And I did have a case of tumor.
They're the experts on their children.
They're the experts. Right? So we want initially when they come in is to look at those red flags. Something's off. It's not a migraine. So to diagnose migraine, for migraine without aura, you need 5 episodes.
Okay.
They have to have some associated symptoms, so nausea, vomiting, light or sound sensitivity. All the exams should be normal. And 85% will have a family history.
Okay.
So once you gather those, you can feel comfortable saying, hey, you do have migraine.
Thank you for mentioning the family history. I was going to just ask a follow-up question. I know that it's definitely more likely, if there is a family history, but I didn't know 85%. That's pretty impressive.
Yeah.
And 85% will have a family history. How far out does that go? Is that in a first-degree relative? Is it?
I would say first, second degree.
Okay.
Now sometimes you have to go pull it out from the mom. The mom say, I have sinus headaches.
Sure.
But you have to get, hey, do you get light sound sensitive? You do, so sometimes we diagnose the mom while we're diagnosing the kid.
Right,
yeah,
absolutely. Yeah. Do you find that there's any maybe certain age that you may, or maybe to guide us as general practitioners in the office, if the story sounds very much like a migraine, but maybe this is a 6-year-old and you're going, this makes me a little bit nervous just being so young. And maybe it is, but is there any age where you would say under this age, maybe referral is indicated or you would be a little more inclined to do imaging immediately? Anything like that?
Usually if the child is younger than 6. They can present with a typical migraine, with a family history. I do say to the parents, everything looks good, but since your child is younger than 6, I'm going to order an MRI. So they really don't need a referral. It's mostly just they're too young, it's headaches, it's unusual. Do we see migraine? Yes, we do see, especially in boys. They come in very young with their migraine. But I do push a little bit towards imaging if they're younger than 6.
So that's very interesting. Is there a more female predominance as we get older for migraines? Yes. Which I feel like is probably what I see more. So very interesting that you said under age 6, more likely to present as boys. So
correct. And it flips around the age 8, 9, and you start seeing more girls than boys. Okay. Half of the boys can outgrow it by the age of 20.
Oh, that's wonderful.
And the girls, it's their best friend.
Oh, no. Not good for them at all.
No.
So we talked about, obviously, any concerning signs on exam, waking them from sleep, especially waking with vomiting. I think one of the other things I always ask about is, do you have this first thing when you wake up in the morning, as opposed to does it develop throughout the day as a red flag? Are there any other things maybe in the history that we didn't go over that you could think of, maybe things not just in the history to be alarmed about, but also maybe there's certain things in the history that would exclude you from calling this a migraine? Like if it's, I know you mentioned occipital headaches, which was a great clue.
So with waking up in the morning, it's a little bit difficult because you want to ask them, does it wake you up in the morning? Because a lot of time they go to bed with a headache, they're going to wake up and they do have a headache. So you have to clarify that part. Other symptoms I'll be concerned is if they say, I only have that really severe headache when I exercise. And it's usually a stabbing headache, does not last too long, goes away when you rest. So this one may guide you towards, is it an aneurysm? Is it a vascular abnormality? So usually for migraine, it should last between 2 to 4 hours. For adult, they say it's 4, but kids, they don't last too long. Okay. So if it's a really severe bad headache, stabbing headaches, even otherwise they have a normal exam, I would be tempted to get an MRI to rule out any vascular abnormality. Once we get the imaging, we can say it's a primary headache, primary stabbing headache, and treat it as such.
Yeah, absolutely. Obviously, I think, and we didn't mention this, and I probably should have, but, a full set of vital signs, blood pressure, those sorts of things. And the other thing I thought about is I always try to remember to ask about other visual changes. Have we had an eye exam recently? Have we had, because, very occasionally I feel like you'll have someone that maybe has glasses and hasn't been seen in 2 years, and their prescription's different. And maybe that doesn't exclude migraines, but you definitely want to rule that out, that could be contributing or triggering.
Yeah. So a lot of patients with C, they've been already through the ophthalmologist, they've been through allergy, through everything before they get NCS. But these are triggers. So if they have migraine, it's not actually the cause, it's a trigger for a migraine attack.
Gotcha. Thank you.
But for the eyes, since you mentioned it, you want to look into an aura. Do they have any visual changes before the headache starts? Do they have any sensory changes before the headache starts? Some people call it ocular migraine, which most of the time is just an aura, that's another sign. So the aura should not last more than an hour. So it's unusual, and we won't be able to call it migraine with aura. If it's lasting too long, we have to do other workup.
Sure. Yeah, that sounds great. So I kind of delving into a little bit about options for prevention, and even we'll go really delve into treatment here in a bit, but one of the things that I also try to elicit in my history is just sleeping. Do we have good sleep hygiene? How is our diet? Are we exercising? Kind of all of those healthy habits. How much of an effect do those things have on migraines?
That's a big part of the treatment, actually, when we discuss with them is I usually say we can put you on a preventive medicine. That is not enough, and it's not going to help unless you really take good care of yourself. And we go through hydration. How important is it? Controlling, not drinking a lot of caffeine. It dehydrates you, can give you a headache. Exercising just to increase your endorphins, and that makes you feel good, at least 30 minutes every day. Eating well, breakfast, lunch, dinner, green vegetables, and make sure you're healthy. Sleep, especially in teenagers. And we do recommend 8 to 10 hours of sleep. And I tell them just think about your bed as a wireless charger. You need to charge your brain.
Sure.
And you need a minimum of 8 hours, or your brain will be irritable the next day. You'll be anxious. You'll have headaches.
Sure. No, that is a great point. So those things, obviously, go into eliciting the history, but also in recommendations for treatment.
Correct.
The other thing is, how often would you say, I do feel like I often recommend initially to really kind of keep a headache diary, per se, or track these headaches to see if you can identify a trigger, if you can. How often do you feel like parents or patients actually will identify very specific triggers?
It is very hard to find a trigger. So I don't push them. The diary mostly for us is for them to have an idea how their headache are. If the treatment we gave them is working, because let's say they're doing it the right way, it doesn't work, we have other options to offer.
Gotcha.
Anything can trigger a headache, change in the weather, dehydration, so little things they don't even think about.
Good to know. So more to log how often, how frequent, and to assess treatment success more than triggers.
Yeah.
That is good to know, because I feel like that's something we hear a lot about. I can't say in my practice that I've seen a lot of people who come in and they say every time. I do feel like sometimes with, and probably not as much headaches occasionally, but headaches and like dizzy spells, we'll be able to, identify triggers of like very hot weather and things like that. But probably not so much just with migraine. So thank you for
It's hard to find a trigger. Stress, some teenager will tell you when I'm stressed, so we do, which not unusual.
Right.
Yeah.
Sure. So we mentioned, tracking more for treatment success, but what other, maybe even just medication type things can we recommend for treatment? So you mentioned fluid. Would you like to speak to, how many ounces a day of water you like to recommend, what you prefer to do with electrolytes, onset of headache, those sorts of things?
So for hydration, when they're having a headache, we do recommend something with electrolytes. And now there's tons out there in the market. So I used to say Gatorade, Powerade. Now I tell them whatever you like that has electrolyte, no caffeine. It's mostly during the headache because it's an inflammatory process. It's the blood vessel stretching. You want to fill it up as soon as possible. Now, during the day, the hydration, it depends on their on their age and their weight. For the electrolytes during the headache, I'll go from 16 ounce for the little kids to 28 ounce for the older kids. If they're concerned, we want the sugar. So I know a lot of parents are worried about the sugar during the attack. We want the sugar, but if they're really concerned with weight or things like that, that's okay to use a one with low sugar. Sure. During the day, they can drink anything they want. No caffeine. So we're really strict. If their headache are under good control once in a while, it's okay. And I'll tell them that day you need to drink more. For 6, younger, or 8, and they're not, so I don't have a definite one, but I will say during the day I'll go from 6 to 8, but for the teenager, I tell them you have to drink 10 to 12 glasses, especially if they're active. and they look at me, I can do that. I will say, it's just a little cup every hour.
Yeah.
And if they're very active, especially in the summer, I would say try to drink sports drinks an hour before you go to your game, to your practice. And that will give you the hydration and an hour to digest it. So at least you go in already hydrated.
Absolutely. I know for the little guys, I try to stay more in the kind of, when I say little guys,
Younger,
prior to teenagers,
yeah.
In that like 60-ounce range, which
Yes.
sounds like a lot. And I kind of use, when you said cups, I'll say, a water bottle like you get at the store, like Aquafina or Dasani, and do 3.5 of those. Like it's more doable, I think, like you said, if you put it, 6
identify
to 8 for the
what,
whole day.
Correct.
Where my teenagers sometimes will push that closer to 100. So you mentioned the 3 healthy meals per day with the green vegetables, and not skipping meals is very important as well. Yeah. Just for us, scientific-brained folks, what physiologically, obviously you get blood sugar fluctuations, is that what we think
That's
the main
mainly
contributing factor is?
Correct. And when you see your teenagers, what are they skipping the most? Is breakfast. They wake up, I don't feel like I'm in a hurry, I don't want to eat. They've been sleeping all that time, they're not really eating. So I tell them, you're not eating unless you tell me you eat when you're asleep, and you wake up, you go to school with the brain that's really with no fuel. How is it going to work? And it's mostly sugar changes, electrolytes changes, that they're not pathological. But if you have migraine, your body can feel it, you're more sensitive than others. So what I tell them, I understand, just grab a protein bar. That will be plenty. Grab something, you cannot go without breakfast.
Something easy to eat on the way to school that doesn't interrupt your sleep, right?
Correct.
So you can still sleep in. So you mentioned the green vegetables. Obviously, lots of wonderful vitamins, but I think one of the big things would be the vitamin B2 in green vegetables.
Correct, the riboflavin.
Yes.
Yeah.
Do you ever recommend additional riboflavin or, say, vitamin D, CoQ10, any of those? And we can approach those one at a time if you would like. Or
Well, we do. There's a lot of study that showed patients with migraine can have low vitamin B2, low vitamin D, low coenzyme Q10, and now folic acid, especially with migraine with aura. So in the headache center, we do the levels. So if the levels are low, then we start, because it's a lot. We don't want to do like 4 vitamins if they don't need them.
Makes sense.
I don't know how practical it is in the office, and not all headache specialists will do the labs. So we usually, vitamin D, a lot of us are depleted from vitamin D, so probably you may be doing the level anyway.
Sure.
For vitamin B2 in the office, I will say from the history, if you feel like they're not eating a lot of green, they're against eating the green, I would add the vitamin B2 instead of another one and tell them that can help with the headache.
That's a great little pearl, I think, to think about it in that way.
So you can pick any of those and start it before you start even a preventive medicine and see how they do in 6 weeks.
CoQ10, any, I guess, without necessarily drawing the level? Or maybe you feel like that's one you just would probably have to get the level, and that's okay too.
You can start it. It does not have side effects. And even if they take it, the CoQ10 is more a mitochondrial enzyme that helps. And migraine, this is where it starts initially. And you can do B2 and CoQ10. But the main thing is not to overwhelm them with pills.
Sure.
If you think about it, a daily pill for us is a lot. For a teenager, ugh.
Absolutely.
No.
Do you have ages that you would say, below age, 8, I wouldn't do those? Or even dosing-wise, how much of each of those you would recommend?
We usually use them. We do the blood level if a patient is going to go on preventive or they have more than 2 headaches a week. Okay. So these are the patient we would do the blood work. So I would not use those vitamins if they're having 1 headache a week. So it's not for all the patients. The younger kids who cannot swallow pills, most of the time I don't, because a lot of them are pills, they don't come in liquids.
Sure.
If they can't swallow pills, they have a lot of headaches, then I would start it.
Go ahead and try it. Yeah. And how about actual doses?
So for the B2, is 50 milligram twice a day. If they're less than 30 kilos, you can do 25 twice a day or 50 once a day.
Perfect.
Same for CoQ10, it's 100 a day if they're low, and you have it if they're less than 30 kilos.
Okay.
The vitamin D, it depends on the level. If it's less than 30, we use the higher dose. If they're older, more than 30 kilo, I'll do the 50,000 once a week for 8 weeks, then switch to the 2,000 every day.
Okay.
If they're younger, 20,000 every week for 8 weeks.
Great. Absolutely. So moving on, before I think I'm going to leave true medicine treatment to the end here, but how about the role that maybe CBT or cognitive behavioral therapy may play in helping with managing migraines for patients and families?
A lot. There have been a lot of studies showing that CBT for pain is very important. It's just to make sure the family and the patient understand what is CBT. It's just learning coping skills. We're not sending you because we think it's in your head. We believe you have headaches. We're just sending you to learn those skills, to prevent the triggers, how to deal with the triggers so you don't end up with a headache. We did a study comparing amitriptyline. In one group, amitriptyline with CBT. They both did well, but the patient who received CBT with the amitriptyline did much better.
Than just the amitriptyline.
Just the amitriptyline by itself. So that by itself showed CBT is very important. And it's easy to do it now. They do it through telehealth. You don't have to come in. And there's a lot of apps. They're not very detailed, but there's a lot of apps. Patient can go in and try to do it. Children's is doing a lot of studies on CBT to understand the pathophysiology, to understand if we can do it just in 20, 40 minutes. Another one, how do we do it through telehealth? So if anybody's interested with your patients, there's a lot going on about CBT.
Are there any specific apps you recommend? I just, as you said that, I thought, I feel like that would be great for the teenagers too. A lot of when I recommend any kind of therapy, I feel like it's more, not that people are always against it, but just having to do it, having to go to it, finding the time. So I thought that is what a wonderful resource that
there's
a
teenager
list. Could.
I don't know if it is with. I thought we send it through. With a plan
community
for
practice.
Yeah, there should be a list,
support tool.
And we can add it at the end.
Well, and we can actually put that on the podcast page here. So we'll have a link to the community practice support tool and make sure that those apps are included, because I think that would be a great resource. Yes. So wonderful. Moving along to more, let's delve into a little bit of abortive therapy. I think some of the most common ones that most primary pediatricians would be familiar with would be Imitrex, Maxalt. Could you go ahead and just speak a little bit towards maybe ages you recommend to use those, which one you would prefer over another, side effects, even dosing, all those things. So,
do you want to start with something even simpler? Because this is what we even start. Migraine, like I said, it's an inflammatory process, so the easiest medicine that works are the NSAIDs. If a patient comes in even to the headache center, I know they've tried ibuprofen. They usually don't take it at onset. They don't take the right dose. So initially, the goal is to start with an NSAID at 10 to 15 milligram per kilo. So it's a little bit higher dose. Even the parents, this is not on the box. I would tell them on the box is every 6 hours for fever. For us, we really need to hit the migraine right away. We do teach the patient that they need to take the medicine as soon as the headache starts, because you want to hit the inflammation when it's small. This is when we add the fluids, the spore strings, and then they can repeat it in 3-4 hours if the headache is still there. So the goal for a good treatment is the headache to be gone in an hour or 2 and they're back to themselves. So that's the goal we're looking. And they can treat 3 headaches a week with those medicine, not more.
Thank you.
And they say, well, we can alternate with Tylenol. I say, no, any pain medicine for headache can throw you into a rebound headache. So if they have some...
Good to know, because I think we always feel like that's only linked with NSAIDs. So.
I think it's our fault, because when we put it, we say, we just mention ibuprofen not to use more than 3 days a week, so we don't specify that. And I realized that when I read my note, I said, we're not saying any analgesic can cause that. Now, this is when we tell them to write down every time they had a headache, how long it lasts, so when they come back, most of the headache can respond to let's say, the ibuprofen, but some of them are stubborn. This is when we can add a triptan.
Sure.
As far as triptan, they're all the same. It just depends on the insurance, on the tolerability, how do you want to give it, PO, if they have a lot of nausea, you want a melt or a nasal spray. The initial one we go to would be rizatriptan, the Maxalt, because it was the first that was approved for 6 and older. And it comes in tablet, it comes in melt. It comes at 5 milligram, it comes in 10 milligrams. So, and we don't have a lot of hard time with insurance to cover it. If they're younger than 30 kilos, I'll do the 5.
Okay.
If they're not responding too well, I would not worry to go to 10 because kids tolerate it really well. Their metabolism is fast, so they tolerate it more than adults. Sure. If they're too nauseous, I will use the Maxalt melt. Okay. If they cannot swallow pills, I will use the melt. Imitrex is similar. It has the nasal spray. It does not taste well. So if they do it the wrong way, they're going to hate using the Imitrex again. Yeah. So you have to know that don't snort it in. It's going to go down. It really tastes bad, and it can give you worsening of the headache. Zolmitriptan is good. It has nasal spray, melt, and tablet. Most of them, the insurance will give them only 9 tablets. The only one that you can get up to 12 would be the rizatriptan.
Okay.
So a lot of time we start with that. Most frequent side effect, if they're going to happen, I'll tell them you can have tightness in the jaw, in the chest. It's not a heart attack. Hydrate. If it bothers you, you give us a call. We'll switch to another one. So if they have it with one triptan, they don't have to have it with the second one.
That's great.
Rizatriptan, they can feel very tired. So some patient will say, I cannot get up when I take it. So I will switch to a different treatment.
I was thinking that might be a desired side effect if you're having a migraine, right?
Yes. We want them functional. Sure, we want them functional.
Sure. So, and then in terms of repeating doses of your triptan, what time frame do you usually recommend for families to repeat?
So we tell them to take it as soon as the pain starts. If they know it's a really bad headache from the beginning, we do combine it with the NSAIDs. Okay. So take them together. They can repeat the triptan 2 hours later.
Great.
And then the only limitation with the triptan, you can use it up to 6 to 8 headaches a month, but they do account into those 3 a week.
Gotcha. That makes sense. Is there a certain time frame, and maybe not, as I'm getting ready to ask this, I'm like, I feel like a relatively vague question, so I'll apologize ahead of time, but maybe a time frame where we've tried all these things. Maybe they're on a triptan. They've done 2 doses. They've done the ibuprofen with it, their hydration as they're supposed to, hopefully, where you would say, you know what, beyond 8 hours, if you're getting no relief and this is just a debilitating migraine, a trip to the emergency room or to talk about, do we need fluids? Do we need some other, form of IV treatment?
So, yes, they do. If they treated it the right way. So the first thing when they call us, we ask them, did you do this? Did you do that? You will be surprised. A lot of them probably have not tried the abortive treatment. Migraine is an outpatient treatment. But yes, when a teenager gets to a point, I did everything, I'm not functioning, we have to be aggressive, not only to get them to function, but we can throw them into a chronic headache. And it's hard to control. Once a teenager girl gets into that pattern, it's going to be really hard to control. So I usually say if they maximize their outpatient and they're disabled, they need an IV treatment with fluids and compazine, Toradol, and things like that.
Sure. Thank you. And then what would be maybe an amount? I know you've mentioned, I think we kind of threw out 3 headaches per week. What would maybe be an amount of headaches or maybe a severity of headaches that we as primary care pediatricians should say we either need to consider referral for maybe a daily preventative treatment or maybe there are some daily preventative treatments that maybe not. This is why you're here to tell me. But whether you feel like once we get to that point, they probably should see a neurology specialist, or are there certain daily preventative treatments that you feel primary pediatricians should feel comfortable trying in their offices?
Yeah. So the issue with migraine, we don't have a lot that are FDA approved. And that's the concern, I think, sometimes with primary care, and I understand it very well. Any patient who's having 2 headaches or more a week, especially if they're disabled. So you look, are you missing a lot of school? Are you able to do your sports? This is when I start discussing preventive medicine. I don't like to push it right away. I do discuss it in the initial visit. It's disabling. There are options. It would be great if any preventive is started in the primary care office. I think you're totally competent to use them. The initial one would be amitriptyline or topiramate. So topiramate is approved for kids 12 and older. Amitriptyline, they're not going to do any study. It's so old.
Sure.
Usually discuss comorbidities. They don't sleep well, but they're not suicidal. I would start with amitriptyline. It's once a day. It's easy to take. They don't have to do blood work. And we increase it really slowly because if they're too sleepy, they're not going to take the medicine. So over 2 months to about 1 per kilo.
Okay.
The topiramate, it's similar. They're overweight. They worry about gaining weight on the amitriptyline. So I would start the topiramate. And surprisingly, teenagers will pick this one, even if they should not be losing weight. And we do go up very slowly. The main side effect that we worry, if we go too fast, they're going to feel foggy.
Okay.
And they will stop taking it, so it's not worth it.
Sure.
When I said I don't push it because of the CHAMP study that compared amitriptyline, Topamax, and placebo, they all work the same. So in the initial visit, unless they're really disabled, I say these are the options. And if you tell me you don't want to start right now, that's okay, because you're going to promise you're going to treat it well, you're going to do your healthy habit, and we'll see you in 6 weeks. If in 6 weeks you've done all this and you're still disabled, the headache are frequent, then we have to be more aggressive.
Sure. You mentioned no blood work required before amitriptyline. Any other monitoring for that one that we need to be aware of? Cardiac, anything like that?
I would not worry unless they tell you I have palpitation or heartbeat problem. Then I would do an EKG. If during the course of the treatment they call and they complain of palpitation, then I would do an EKG. Otherwise, not on the protocol, yeah.
And then for Topamax or topiramate, any blood work that you recommend before?
Yes. So we do the CBC, the renal profile before, just to have a baseline. Most of the time, we repeat it when they're on the full dose, and we keep an eye just for the acidosis and things like that can happen with it.
And I know you mentioned once they would get to full dose, you would repeat it. And then monitoring after that, would you recommend like every 6 months, every 3 months?
I hope by 6 months they're done with it and they're doing really well.
Great.
We do it in the headache center. It's a research center, so every time they come in to the clinic, we do it.
Sure.
But to be practical, if the level is fine when they come in, everything is doing well, 3 months is perfect.
Yeah. So curious talking about these things, this just kind of came to mind. Are there any studies that really go through and look at if patients are very good with their true preventative therapies, with their water intake, their good sleeping, their electrolytes, how effective just those more kind of preventative treatments are at preventing migraines in general, as opposed to having to move to, or maybe there's not really any way you can predict that, but I feel like we really do have some good tools to prevent.
Yeah.
And most of the time, the difficult part here is getting them to actually do the preventative therapies, because I feel like they work the majority of the time if they really are good about it. I just didn't know if there was any data to say, 80% of the time, if they get their fluid intake in, or they have their electrolytes, and even just go as far as some NSAIDs at the beginning of their migraine, that this takes care of that without need for prescription medications.
I would tell our kids it's about 70%.
Okay.
It's not 67, it's around that, just because of the CHAMP study.
Okay.
What changed in the CHAMP study to have those results responding to the placebo, because all the centers had to follow the protocol where they have to stick with a healthy habit. They have to accept that the patient has headaches, that the patient is comfortable, somebody's listening to them. So that's what made the big difference. There's a study just figuring out how placebo work in the brain for headaches, but those changes made a big difference, and that's why I don't push for preventive unless they've done all this for the 6 weeks and they still have those intractable headache. And we have to think about other comorbidities. If they're anxious a lot, we really need to take care of that, and they need to understand it's not just a pill. You need to learn your coping skills that can prevent the headaches too.
And the CBT, like
and
we
the
talked
CBT,
about, which
yeah,
is great.
yeah.
I think that's just a great ballpark number for us to have in mind when I'm discussing this with patients or with parents and say, almost 3/4 of the time we can take care of these headaches without having to do prescription medication, which I think those are fairly good odds considering. So, as we kind of more wrap up treatment options, would you like to mention, are there any specific devices on the horizon? I don't think any that are super widely used right now, but just maybe some things for us to be aware of in the future that may be coming up.
Of course. There's quite a few devices, very interesting devices that are actually FDA cleared for migraine, for acute and preventive. The one we widely use at Children in the Headache Center is called Nerivio. It's like a band you put on your arm. The patient control it with the phone, and they control how strong they want it. It does not hurt. It's a vibration. But if they have a bad headache, they're sensitive, they have allodynia. So they control it, keep it for 45 minutes to break the headache. And the way I usually describe it, I tell them it does trick the brain. Your brain cannot take two stimulus coming in. And when you start this, it's going to forget about your headaches. And I'll be talking to them. I said, imagine the door opens. What are you going to do? You're going to ignore me. You're going to look at the door. It has been cleared for 12 and older. It has been cleared for chronic migraine. If you use it every other day, it can desensitize your brain from all the stimulus for migraine. And it can be used as a preventive treatment. Wow. It's a prescription. And they will mail it to them. The only thing, some states, some insurance approve it, some not. They're still working on that.
That was going to be my follow-up. But I feel like that comes with time, I think.
Correct.
And, more studies that show its benefit, then hopefully, insurance companies will jump on board and say, well, this is a lot better than all the expensive medication, right?
And I want to mention, Jill, one thing is and we didn't mention it before, is the medication overuse headache. And these patients, at one point, if they're really overusing them, by definition, it's a chronic headache, and they've been using medication very often, more than 3 times a week for 3 months.
Okay.
And these patients needs to go off any pain medicine. So during that month, 4 weeks to 6 weeks, it's mostly the hydration as acute, and this is where the devices can get in. Hey, you have something to use. The other thing with the devices, they don't need to leave the classroom. So the headache starts, you put it on, because a lot get anxious. I'm going to leave. I don't want to leave the classroom. They just put it on and they treat it.
That's great. It reminded me as you were talking, hearing you talk about it, of the little, I'm sure you've seen the Buzzy devices that they use
for pain in the OR and things like that.
And the ER. And I've even had parents come in with them when kids are getting injections. And the same idea. It's vibrate the same idea, and buzz. And
it goes straight to that.
That makes sense,
yes.
right? Which are great. So I always like to kind of mention, as we wrap things up, that neurology, I believe, is available via e-consult if we have any patients that we're just really struggling with, or, maybe we make a referral to the headache clinic, and, the patient's going, oh, my goodness, I can't wait 6 weeks, where I'm thinking, that's not that long, but I'm not living with that headache. But is e-consult available for, maybe those difficult patients for guidance from the experts at the
Yes, there's an e-consult that was already established. Now they're starting a new one. So I don't know if it's active for you. If they sent you the information, e-consult is available, and you specify headaches, then we get it goes to the headache specialist. And I think I put in my email, if there is any issue, anybody can email me.
Wonderful. Well, I appreciate that. I think this has been a wonderful talk, and I've learned a lot, which I very much appreciate. This, like I said, sometimes I feel like headaches can be so stubborn that, I don't want to say I dread treating them in the office, but I just feel like it's a very difficult thing sometimes. Correct. To have this wonderful information, other treatment options, other things that I feel like I'll be able to offer to patients now has been wonderful.
One thing we offer, and it's very helpful, is first a school note with the ibuprofen, sports drinks, be allowed to eat, drink in the classroom, go to the restroom. They're scared to drink because they're not allowed to go to the restroom. That's on the note. If it's really chronic, affecting their work, and they're missing school, we do give them a 504, and we tell them this is not for you an excuse to stay home. This is actually a note to be able to stay at school. So we say they need to give them some flexibility. If the noise bothers them, they need to allow them to come in the classroom a little bit later. So a little bit flexibility with testing and things like that. And that relaxes the teenager who really straight A student, this cannot happen. And we do offer these.
Wonderful.
And again, we specify it's not to miss school. It's to make you be in school.
Yeah, that's a great way to think about it. Wow. Well, this has been a wonderful 40 minutes or so learning about, it's been great. So I appreciate all your expertise.
Thank you.
And we very much enjoyed having you here, and I'm excited to share all these pearls of wisdom with our audience.
Great.
Thank you so much.
You're welcome. Thank you.